We are live in YouTube. And we are going live in 5, 4, 3, 2. We are live.
Thank you for joining us on our inaugural Pediatric Neurosurgical Symposium. Today, we're going to kick off our series with Drs. Gumnerova and Suadain, discussing the changing landscape of pediatric neurosurgical oncology. Our goal with this series is really to make this interactive. So just send us any questions you have or comments via the question and answer function, and we'll present them to our speakers at the conclusion when we will have time for questions and answers. Heather?
Yep. So I think both of our speakers today need very little introduction as being huge experts in this field. When we started thinking about who we wanted to have talk for our inaugural symposium, Liliana Gumnerova and Mark Suadain both immediately came to mind. Personally speaking, I can tell you they are two of the most fantastic surgeons that I know. I feel incredibly fortunate to have trained with both of them. Mark in residency at Cornell and Sloan Kettering, and I had the opportunity to work with Liliana Gumnarova during my fellowship at Boston Children's, where she ran the pediatric neuro-oncology program there. I feel very privileged to introduce the two of them, and I think you're both going to really enjoy their talks. First off, we're going to hear about low-grade glioma from Liliana Gumnarova, and then we're going to hear about high-grade glioma from Mark Swedan. After that, we'll turn this over for questions, so please ask us questions as we go along. Thank you so much for both speaking today.
Thank you. So thank you very much, Heather and Toba, for the invitation. And it's going to be fun, I think, to have this with Mark. And we've decided to divide this into low-grade and high-grade glioma. So I will talk about low-grade glioma and Mark will talk about high grades. I have no financial disclosures. So I wanted to start with a little example and why high-grade, low-grade gliomas. And this is going to be my paradigm looking at the low-grade gliomas in the optic pathway area. So this is a 5-month-old child with macrocephaly and visual issues who in 1999 presented to us with this large mass. And then fast forward 15 years, this is the MRI. And one would say this looks great. Now, what we don't see here, obviously, is what's happened in between. And here is what we have in between. This child has undergone 6 different chemotherapy regimens, has significant developmental delay, is blind, barely walks, obviously has a number of other issues, including seizures, has multiple endocrinopathies. And then on routine imaging has this new lesion, has also undergone 6 different chemotherapy regimens. So at this point, the question is what to do. And a biopsy was performed of this lesion, which if you look back at the prior study, this is a somewhat different appearing tumor and is cystic and solid. And a biopsy demonstrated that this is a BRAF V600E mutation positive low-grade glioma. So this is actually sort of the beginning of my talk about low-grade gliomas. And what I wanted to start with is what I think is really critically important whenever we deal with these lesions. And that is that the people who are essential in these are the people who allow us to understand what the biology is, the surgeons, adjuvant therapies, and I think critically the novel biologically driven targeted therapies. And really, when we talk about the evolving landscape, it is the comprehensive team approach that is probably one of the most important things in dealing with pediatric brain tumors in this environment. As we all know, location matters, and that has to do with the surgical aspect of it. So if I have a low-grade glioma in the cerebellum, it's pretty straightforward. We can probably take it out, and this will hopefully lead to a good outcome. But if we have a low-grade glioma, and by the way, both of these are so-called pilocytic astrocytomas, in this location in the suprasellar area, that is not a tumor that can be completely resected and has a very different outcome. And the results on low-grade glioma and role of surgery are well summarized by Jeff Wisoff and through the Children's Oncology Group, COG, multi-center randomized trial, which he ran, and the data were published in 2011. And what it showed is that progression-free survival, if you had a gross total resection, was over 85%, but not a cure. So I think that is important to recognize, in that even though surgery can be beneficial, we still need to do something else. And subtotal resection was defined if there was grossly visible tumor. And that progression-free survival was under 50%. So I think this is really important to recognize that even though surgery has a significant benefit and role, there really needs to be adjuvant therapy after that. A lot is being said about the intraoperative MRI and other adjuncts in the operating room, and there is no doubt that they improve our ability to do a complete resection. However, it has not been shown with 10-year and 15-year survival statistics for low-grade glioma that any of these things have made a significant impact. So I think until we have large data sets of patients where these have been utilized for low-grade gliomas, we still won't know the exact answer. I think the biggest advances in the treatment of low-grade gliomas when it comes to adjuvant therapy were in the early 1990s when Roger Packer introduced the concept of carboplatin and vincristine for both recurrent and newly diagnosed low-grade gliomas. And this is a seminal paper. And subsequent to that, multiple other studies have demonstrated the role of chemotherapy. And this is based on that chemotherapy regimen on vincristine and carboplatin, but also using TPCV. And both of those regimens have similar outcomes. But as you can see, these patients have survival statistics in the 50% area. No significant difference between vincarbo and TPCV. And neurofibromatosis patients were assigned to the standard regimen of vincarbo. And again, they had similar outcomes. So clearly, even chemotherapy is effective, but not 100%. And there are other trials. These are some more recent trials looking at chemotherapy for low-grade gliomas. The PSYOP phase 3 randomized trial, which added etoposide, and then the Canadian Pediatric Brain Tumor Consortium trial added vinblastine. And all of these show very, very similar outcomes. So again, we're doing okay, but not curing these tumors. And radiation therapy, we have not been using, or at least have been avoiding it and keeping it as the last therapy. Nowadays, with conformal radiation therapy, there is a study through the Children's Oncology Group, ACNS 0221, which is looking at the outcome in patients with unresectable tumors with reduced volumes, a much tighter field, and 54 gray, and the data are coming out from that. But the point I'm making here is that we need to do something for these patients. So the reason we also don't do radiation therapy is because vasculopathy and endocrinopathies are very commonly seen in patients who've received radiation therapy as well for low-grade gliomas as it is for high-grade gliomas, and cognitive decline. So I think the next important step after the introduction of chemotherapy, which was able to halt progression in about 50% of the patient, was the identification of the molecular characteristics of low-grade gliomas. And these are the two seminal papers that came out in the 2008 and 2009. And the first one from Korshunov and the group in Germany demonstrated that pediatric low-grade gliomas are different from adult low-grade gliomas, or the pilocytic from the diffuse astrocytoma. And then David Jones and his group demonstrated that this duplication, tandem duplication leading to a fusion, is what defines the majority of pilocytic astrocytomas. And just for very briefly, I want to say what this all means is essentially the BRAF gene, there is a fusion at this site, 7q34, which leads to a duplication fusion. And this is called the BRAF KIAA 1549 fusion gene. And here, BRAF lacks its autoinhibitory domain and then becomes constitutively active downstream of the MAP kinase and the ERK pathways. This is present in almost all pediatric pilocytic astrocytomas, 60 to 80%. There is another mutation, which is the V600E mutation, which I will mention in a second. It's less frequently seen in the pilocytic astrocytomas in approximately 10%. And those patients who have the V600E mutation have a worse outcome than the patients who do not have it. And these are the two very important identifications of low-grade glioma abnormalities. Because of this downstream activation, there has been a focus on inhibition of the signaling pathways, and you can have blocking of the MEK1/2 MEP-ERK kinase with specific targeted drugs, and I'll talk a little bit about them down the road, selumetinib, and then specific targeting of the V600E mutations. These are the drugs that you may have heard, and also anti-angiogenic therapies. So the one thing to remember, pilocytic astrocytomas have this duplication fusion, and then there is, in a small percentage of the patient, a V600E mutation. And these are infrequently seen in diffuse astrocytomas, and conversely, the IDH1 gene is not seen in pediatric low-grade gliomas. And again, here, this is a paper that came out of the Children's and the Dana-Farber when I was there, and we could see that there were specific mutations for the different subtypes of astrocytoma. The diffuse astrocytoma had a MIB-L1 truncation. The angiocentric glioma had a MIB-QK1 truncation. Gangliogliomas had a BRAF V600E mutation, and this is very characteristic for ganglioglioma and also for the PXAs, the xanthoastrocytoma. And then the pilocytic astrocytomas have the BRAF duplication. And then we have these not otherwise specified low-grade gliomas who have a variety of abnormalities. And this is actually a nice way to remember the different subsets of low-grade glioma and the abnormalities that are associated with them. And this is another slide that actually is from a paper by Ian Pollock in JNS Pediatrics, which essentially demonstrates the same. Here is the BRAF gene, and you have the fusion or the mutation, downstream activation, here MAC-ERK, and leads to cell growth. And what's, I think, interesting here is that you can see the location of where these abnormalities are. So the KIAA1549 BRAF complex is usually seen in these locations, cortex and cerebellum, whereas the PXAs and the gangliogliomas have the BRAF V600E mutation. And here in this location, number 2, the optic pathways, they also have pilocytic astrocytomas, but they also will frequently have V600E mutation, which leads to slightly worse prognosis. So going back to our patients, here is a patient who I operated on. She presented with visual symptoms and some mild hydrocephalus. We did a biopsy, and this was a JPA. And then 7 years later, she has now had multiple chemotherapy regimens and now has undergone a craniotomy for debulking and now has a shunting. And the biopsy at this time now shows that this tumor actually does not have a mutation, so we cannot give her a targeted therapy V600E, so she's on a MEK inhibitor, which is one of these downstream inhibitors. Now, unfortunately, she now has a hemiparesis where she started out being well before. The goal with the chemotherapy here, with the targeted therapy, is we want to make sure that she actually continues to do well. And why do we want to do that? And that is because we know that low-grade gliomas will survive if we control their disease into their early 20s. And this is a paper out of our group again that looked at the SEER database and showed that patients with low-grade gliomas will stabilize their disease. And the break point is about 22 to 23 years of age. So if we can carry these patients through that age, then we don't have to worry about the tumor because they don't seem to grow beyond. The other thing that this slide shows is that irrespective of degree of resection, this is complete resection, subtotal resection, complete subtotal, patients who underwent radiation therapy had a much worse outcome. So that's the other point to make here about the biology, is that low-grade gliomas should not be treated with radiation therapy unless absolutely necessary. So here are some cases and the goals of management. This is a patient with diencephalic syndrome and shunt that failed, which is not unusual, and ascites. So they came to our institution with this scan. And the goal of surgery here is we want to deal with the hydrocephalus, but also recognizing that this patient should be treated with chemotherapy, and hopefully if we get the disease to stabilize, we'll do better. So we took this patient to the operating room, and you can see here the tumor in the aqueduct. And I have to show at least one operative picture. So this is our interhemispheric approach into the third ventricle via the right foramen of Monroe, and there's the tumor. And you can do a very nice debulking. And in the end, this is actually the aqueduct that I'm looking at that is filled with CSF that we have unplugged. And this is the post-operative image that shows that we have done a significant debulking. The aqueduct is now unplugged. And she actually did very well. Unfortunately, though, she died a year later from progressive disease and complications. So even though we were able to stabilize the disease, she had a bad outcome. On the other hand, here's another patient with a similar massive tumor in the suprasellar optic pathway area who presented to us at age 2 with hydrocephalus, developmental decline, had been tried on zinc carbo, had a prior operation elsewhere, and when we saw him, we basically decided to do palliative debulking operation, which we performed. And he then was resumed on chemotherapy. And this is the scan at the beginning of chemotherapy, a year later, essentially no disease. So this child is one of those children who we then think of, are we going to be able to make him survive until age 20 or 22? And what would we do if there is further progression? I think before I go to that, I wanted to point out why we did reoperation. And some people would say that I'm an aggressive surgeon, or I used to be an aggressive surgeon. And I think that the point is that there is a role for reoperation in low-grade gliomas. And oftentimes, once we have a low-grade glioma that is initially thought to be unresectable, frequently there is a tendency to just do chemotherapy and radiation therapy and not think about another operation. And the other thing that I've also started to think of is low-grade glioma management long-term more as a chronic illness rather than as an acute neoplasia. So if you look at treatment and presentation, you have to deal with your acute toxicity and then give chemo and targeted therapy. And then the maintenance therapy obviously includes chemo. But I wanted just to make a point that there is a role for reoperation for low-grade gliomas. And we looked at our experience. This is one of my previous fellows, looked at our data set from 1990 to 2016 when I was at the Children's Hospital, and there were 547 patients with low-grade gliomas, and these are the exclusion criteria. All patients had to have pathologic proven disease. Ultimately, the cohort consisted of 279 patients. This is their mean age, follow-up, and the follow-up in some patients were up to 30 years. And this is a picture that I like to show because this patient presented when he was a year of age with an exophytic brainstem glioma that I subtotally resected. He was treated with chemotherapy for his recurrence, and he's now applying to college and is neurologically intact and doing fantastically. So this is what we are striving for whenever we're managing these patients. So we looked at this cohort of patients. This is the standard, as you can see, pathologies and location. The majority of the cases were in the posterior fossa. And when I'm looking here at outcome, these are patients who have actually had no surgical or have had surgical complications. And interestingly enough, posterior fossa patients have a lot of complications, but we were very strict. Any patient who had even esotropia or cranial nerve palsy was felt to be a complication. But I just wanted to point here. One thing always people worry about is extent of resection and outcome. Did it make a difference? And actually, when you're doing a gross total or near total resection, you're presumably being more aggressive. The complication rate was not higher than when you had subtotal or biopsies. And perhaps one could argue that the subtotal is because they're in more eloquent areas. But I think it's important to recognize that you can actually do surgical resection. And the complication rates, we looked at the complication rates as far as number of operations, first, second, third, and fourth operation. And it didn't seem that there was an increase in the complication rate with each operation, either for the post fossa or in the lobar area. So, and then we looked at adjuvant chemotherapy. I think, as you can see, there is a number of complications. Mean number of regimens per patient was 2. And I think there's a couple of very significant complications. We had 2 patients who developed AML, one of whom died, and 2 patients who developed MDS. So the point I wanted to make, and this is going to be in sort of an introduction to the targeted therapy, is that there is a role for surgery. It has to be goal-directed. And then I think in these patients where we may not have tissue, now that we have targeted therapy, there may be a role to get tissue. And this gets us back to this concept of the comprehensive approach, because every time you have these brain tumor clinics and you're discussing how the patients are doing, you have to think, are there novel biologic therapies? Is there a role for surgery? And what are the adjuvant therapies? And so now fast forward to 2019, 2020, this is a paper that came out in Neuro-Oncology and essentially summarizes the advances that we have now had. So remember, we talked about the activation, BRAF, MEK, ERK. This actually also looks at high-grade gliomas and some of the tuberous sclerosis and neurofibromatosis. But I just want to focus on this area here. We have now BRAF inhibitor towards the V600E, the brafenib, works very effectively. We have MEK inhibitors downstream, and we have TK inhibitors a little bit more upstream. And I'll show you what the data are now. This is a paper that actually is going to, the full paper is coming out in 2021, but this is the preprint. For patients who had BRAF V600E mutation, low-grade and high-grade glioma, 67 patients from multiple institutions, North America, including Canada and Europe, 56 pediatric low-grade gliomas and 11 high-grade gliomas. Objective responses in 80% of the low-grade gliomas versus 20% in conventional chemotherapy, statistically significant. This was a rapid response within a month or 2. It was sustained. Number of patients had decided to get off therapy, and there is regrowth of the inhibitor, but once restarted, again, you see very good response to the BRAF V600E inhibitor. And the progression-free survival in this cohort showed that there is a benefit compared to conventional chemotherapy, again, statistically significant at a p-value of 0.02. So now we actually do have these bullets. And when we now look at a patient who is like this, and you say this is an optic pathway glioma, it used to be that we would just treat this patient empirically with chemotherapy. Now there is definitely a role to do a biopsy so that we can have a targeted therapy, because some of these patients may have other therapeutic targets. And this patient, who is the patient from 11 months, we did not do a biopsy at that time because we empirically treated him with chemotherapy. 3 years later, he presents with a much larger disease and all these complex cysts, which is one other thing that we see in these patients. But the point here is that here we actually did a biopsy, we identified a target, and he's getting targeted therapy. So I think in the interest of time, we don't have a lot of time to talk about it, but I think there have been tremendous advances in neurosurgical oncology, primarily in biology, understanding these tumors, and in imaging. And here again, I want to point out, once you know what the tumor is, you can target these tumors and you can have very good responses. Thank you very much. And I think I'm within the time frame. I apologize. There's a lot to talk about, so I'm looking forward to hearing from the rest.
Thank you, Dr. Gumnerova. I think we're ready for Dr. Swadain next.
That was fantastic. Now we'll switch over the screen sharing.
Good to go?
Yes, please.
Good. Heather, Toba, thank you very much. It's great to be a part of this. Lily, it's also quite touching to share the stage with you. I've always admired the work you do, have done, and looked up to you in many ways. So what I find interesting is the similarities, whether we're talking about high-grade or low-grade gliomas. Some of the key phrases I use, some of the trends I'm going to talk about, they're mirror images. And I think it says a lot about us as surgeons. I do have a disclosure slide, and that's this. I have no financial disclosures at all, but I show this because it is biased, my opinion, my nihilistic opinion in high-grade gliomas in children. I trained with the best of the best with Harold Hoffman and Fred Epstein and Jeff Wissoff, and I came into this career beating my chest and thinking that I was technically as good as anybody else and I could cure GBM. Stephen, who you see on the left here, had this MRI scan done when he was a couple weeks from his high school graduation. I took him through surgery. He did great. GTR, he went to his prom, etc., and he died about 14 months later from a recurrent GBM. And this really slapped me in the face from the standpoint of, really it's not a surgical disease, and it was just so telling from the standpoint of the limits of what we're asked to do as surgeons. So I would not say that I have a nihilistic approach toward malignant hemispheric gliomas, but I will say time and time again, it's far from a surgical entity. The tools we have are limited. There's no question about it. And the three component pieces have typically been surgery, usually the gatekeepers, radiation, and chemotherapy. And those components are done in various ways and almost universally adopted with high-grade gliomas. So how do we use those to the advantage of these kids today? And has this playing field changed? The answer is going to be yes. Obviously, we're asked to do a lot. And not all of these apply to every child. And I kind of already addressed that first bullet point with regard to an oncologic benefit. And I'll get into a little more detail there. And then obviously, these kids come in sick. And we're asked to do things to help them recover and get to their next level of care via various ways. Hydrocephalus, mostly in post-FOS tumors, but this has been kind of the burden that we carry in the longitudinal management of some of these patients. Then obviously the idea about prognostication and how do we gauge and guide our oncologists and radiation oncologists once a diagnosis is made. So there's no shortage of rationale for operating on these kids when they present. Lily addressed the idea of low-grade tumors and the role of meaningful resection. And this, I always tell parents that with very few exceptions, when we're confronted with a new diagnosis, that the oncologic benefit is almost there. That a meaningful resection is better than a subtotal resection, whether we're dealing with malignant tumors, low-grade tumors. This has been played over time and time again with really any tumor variant. You see there for a ependymoma, very extreme. So that the surgeon is always faced with this idea of getting more and more tumor out for a oncologic benefit. And that's changing to some degree, but Lily commented on the cooperative groups. These are really large data sets. And I think looking at these in univariate, multivariate analysis, it always plays out as a variable that's important. And so is true with the hemispheric or the malignant gliomas in children, the malignant astrocytomas. And again, these have been done time and time again. And even though I've mentioned that they're cooperative group studies, you can see that as you get 2-3 years out, the numbers start to diminish in these very large populations. But nevertheless, whether you're talking about the conventional verbiage of an anaplastic astrocytoma or a GBM, clearly in both of those entities, the prognosis was always improved with a gross total resection, however one defines that. Historically, in many of these cooperative group studies, and still today, contrast enhancement has always been kind of the target with regard to the gauge, which we know is very inaccurate. With MRI scan, with flare and T2 signal change, not to mention MR spectroscopy, we know that we're fooling ourselves from the standpoint of the degree of resection. But nevertheless, pans out in high-grade glioma. Both of these are COG studies, and this has been repeated again through the PBTC, through the PNOC, and any other consortia or large institutional throughput that looks at the benefit of extent of resection and malignant tumors in children, malignant hemispheric gliomas. Lily talked about, so if that's the ask, how do we maximize that from the standpoint of surgeons? We push ourselves, we train. The tools that certainly came online since I showed you Stephen's MRI scan that are now in fairly common use, and Lily's published on this as well, is the role for better guidance at the time of surgery. Not just navigational guidance and trajectory planning, but volumetric removal. How do we do better based on these tumors with the demand and the request to take out at least 90+% of the tumor? So, impressively, and we've all kind of dappled with and used in various ways intraoperative MR and MR guidance. In this particular prospective study that was comparing MR assisted versus not, and this is in adults, granted, supratentorial malignant gliomas, really impressive as far as a differential with regard to complete resection. I have access, and I've always kind of used it in my back pocket, but I say if I don't have it, I'm going to push a little harder. So there's that inherent, and when you have it, you'll use it. When you don't, you won't. And one of the other concerns that this group, I think, squashed is this idea that if you push harder and harder and take out more and more tumor, there's going to be more deficits. And I think that was suppressed by this idea that it doesn't push you to the extent of injuring individuals. So that's been kind of the backdrop with regard to assistance in the OR. And again, I'll reserve my comments as it relates to malignant gliomas versus others, but then pushing a little bit further in the realm of nearly cellular resolution. Has been the tumor paint, has been the 5-ALA assisted surgery. Again, adult series, prospective. I think this is a phase 3 study. Looked at the extent of resection utilizing fluorescent emitters, 5-ALA in this case. Impressive again with regard to the degree of resection. This is based on contrast enhancing tumor, none of those other modalities or sequences I was talking about. And like the MR data, in a very, very good prospectively conducted study, no greater morbidity as one might hypothesize based on the desire to take out more and more tumor. And maybe this starts to even out as one gets further out with regard to progression-free survival. But if our goal is removal of contrast-enhancing tumor, both MR and fluorescent emitters have been proven to be useful in the adult world. As we do this, and it's wonderful to have, to some degree, a long-term perspective. And I know Lily's been very involved in cooperative groups, as I have been. And when you see some of these kids, as I have, come back at 15, 20 years, and particularly with regard to low-grade tumors. I showed you Stephen, who died in a year. Some of these low-grade tumors, we pat ourselves on the back at 1 or 2 years out, the MR is stable. But boy, oh boy, do they pay a price from the standpoint of not just surgical, but adjuvant therapy. And Lily made reference to this with radiation therapy. This is a recurring story, and looking at late effects and long-term survivor programs, regardless of the type of tumor. But if we get cure, there is a substantial number of children, be they low grade or high grade, that will pay a price for a very meaningful therapeutic approach. The dynamic aspects of a child's brain, now complementing that, this is looking at really the idea, or not just the idea, but the practical aspect of laying down fibers and connectomes, and how this goes through an apogee and then starts to regress after some period of time. A very, very dynamic process in early childhood. And you start throwing surgery, yes, they can recover, and that's always kind of the defense of the pediatric neurosurgeon. But if we inhibit and interfere with these early on, cognitively, this is a big deal. We've seen this play out in various formats with surgical approaches with regard to fourth ventricle here is one example. How do we reduce this cognitive impairment with posterior fossa mutism? One particular example of how we as a trade have tried to revise this, endoscopic approaches, and this is not to be belittled, by the way, from the standpoint of, I mentioned hydrocephalus, sorry. This practical aspect of morbidity, again, you watch enough kids long-term enough, and they're going to, again, come back to you time and time again where there is a fair amount of morbidity just based on CSF diversion. So, third ventriculostomy, I think, has been, in my career, and watching this over 20 plus years, a huge boom as far as reduction of morbidity for these kids. So integrating these connectomes into our surgical approach, this is something that is now part and parcel of most navigational tools with anatomical references that are built into this. I want to look at these fasciculi, I want to look at motor tracking, you punch a button, and then it's there wrapped around your tumor, and you can integrate it in your navigational guidance. Does it result in better outcome for these kids? Is a whole nother story. Lily did talk about the comprehensive aspect of this. And again, as I watch this transition in 20 years, I've gone from kind of those tools to these tools to these tools. And, and the next iteration is the molecular pathologist, which I haven't even listed here. And it gets highly, highly complex from the standpoint of what do I do? And it's no longer, I'm the gatekeeper here, but there's a lot of other things that are integrated into decision-making. You cannot have an approved protocol through any legitimate cooperative group anymore without including a neuropsychological quality of life assessment and doing this in a very regimented fashion. Why? Because X number of decades ago, parents and caregivers were stomping their feet saying that cure is not our goal. Cure with some preservation, or hopefully all preservation of function and developmental assessment is our goal. So this is now inherent in everything we do. As an example, another trend that's happening, and we're seeing this in malignant gliomas as well, is this idea of de-escalation of therapeutic approaches, whether it be cytotoxic chemotherapy, radiation fields, radiation dose. This is an example of a study schema in malignant germ cell tumors. This idea about, can we harm kids less by dose de-escalation? And this is centered around fields and dose of radiation. We're seeing this in, obviously, medulla with regard to prognostic categories, to the point where it's now influencing surgical decision-making. Do I need to get a GTR in a Wnt sonic hedgehog-driven medulla? And I think there's some voices out there saying that the traditional mindset of a neurosurgeon is not necessarily the take-home. So we're seeing this in malignant gliomas. And when is a GTR important versus not? I think nothing more than, and most importantly, the IDH mutant or wild type phenotype has played a real role in understanding prognosis and possibly, what the surgeon should be thinking at the onset. And this kind of blew things wide open from this. And there's been a lot of receptor status. PDGR was preceding this in several years. But from the standpoint of prognostication, this was a big, big deal in the malignant glioma and non-malignant glioma phenotype. The other big, I think, uptick here was in the epigenetic and the transcriptional control of, namely the histone modifier genes. This, again, equivalent to the IDH mutant phenotype, has been phenomenal as far as rethinking what tumors behave in different ways. There's been a multitude of high-profile papers that have looked at this. And interestingly, our developmental biologists who have watched this in real time, who have been spinning their wheels and talking about developmental biology and neurobiology, said, yeah, we've known this for a long time, that if you throw a mutation in a histone modifying gene, that you're going to have some problem with that. So these type of polycomb receptor complexes up here, made up of many different subunits, rely on the trimethylation of these histones, and they become inhibitory, these inhibitory complexes. So when things go awry, it's kind of a release of function where you get gene expression uncontrolled. And this has been really the focus with regard to malignant phenotypes in children. So these, and they come in different variants, but the H3K27 mutant has been the real focal point here. But this has opened up the door to very rapid, I won't say successful yet, but very rapid attention addressing many, many different elements of this. And I've raised some examples here with regard to histone deacetylase has been one of the big driving forces with regard to molecular phenotypes, BM1, EZH2, and another with regard to combination therapy. I'm going to come back to these in a moment, but again, and this is not limited to just this list, but a lot of attention based on the frequency of the malignant phenotype. So the World Health Organization grabbed hold of this at that intersect and said, back in 2016, we need to redefine the malignant phenotype in both the pediatric and the adult populations. And this is what we deal with now. And this is very basic and it's descriptive. But we're always going to classify these as IDH mutant and wild type when we're dealing with malignant gliomas. And again, grade 2, grade 3, grade 4, colloquially, all are malignant phenotypes, I think, in most persons' mind. We used to throw the diffuse WHO grade 2 into a benign category, but everybody knows and realizes that it will de-differentiate into a malignant phenotype over some course. And then separate is the H3K27 WHO grade 4 tumor. And those become very, very important working diagnoses with regard to the algorithms we're using in the cooperative group studies. Regardless of the phenotype, as I mentioned, WHO grade 2, WHO grade 3, WHO grade 4, PXA, oligo, you throw these into the equation and it makes a big, big difference with regard to outcome. And ultimately, that will affect the way we're going to do things. Lily showed a very interesting case of doing a biopsy, not a subtotal resection in a kid with an optic pathway glioma, and using targeted therapy. We're going to need to know and identify these phenotypes up front. And I think two of the beasts that I've had to deal with in my career are the thalamic gliomas and the pontine gliomas, with regard to just feeling really humble about what we do and what we can't do. So this will be the building blocks moving forward. There's no question about it. And that delves into different surgical enterprises with regard to malignant tumors. This panoply of evolving therapeutics, cell-based, viral-based, liposomes, monoclonal antibodies, large proteins, how do we do a better job? And this really isn't the neurosurgeon's arena. We're trained to take out tumors in an elegant fashion, but the point is that a lot of these will become the domain of the neurosurgeon from the standpoint of the interfaces. Anybody who knows my work know I focus a lot on direct drug delivery through CED. I've really gone down this path aggressively with regard to DIPG. We're not the only group. Others have looked at this. The work that Russ Lonzer and Kathy have done at the NCI really have been instrumental as far as pushing this forward. Jury's still out, but nevertheless, it's taken on a lot of interest. This is some early work done with the group out at UCSF, Nailan Gupta and Sabine Mueller, using a form of panabinostat directly delivered with a surrogate tracer into the brainstem. They just finished their phase 1 study. Those results have not yet been published, but going down this idea of feasibility was very important. We published our results a couple years back now. We're still in the realm of a phase 1 study and dose escalating, treating another kid this week. And we're infusing large volumes of these macromolecules into the brainstem and learning a lot about dosimetry, and learning a lot about what we can accomplish. That hasn't been the only route. Ed Newell has been the champion of this for as long as I've been in neurosurgery. But the conceptual backbone about getting chemotherapy more effectively into our target tissue is real, and that's been proven time and time again. We've evolved with regard to the process. I know Heather's been very involved when she was up at Cornell with super selective intra-arterial delivery. I'll say that the testimony of this has been in the retinoblastoma world. And if you look at retinoblastoma with very precise intra-arterial drug delivery, the type of responses you can get, if you can have the angioarchitecture matched with the therapeutic drug is really powerful. We have in draft form right now such a program for choroid plexus tumors, which are a burden for the pediatric neurosurgeon. This is fastly coming online as well. This is work that's been done up at Toronto with Jim Retka as a senior author, looking at focused ultrasound, which is essentially now in common use for movement disorders, but rather than an ablative tool, one to enhance drug delivery. Again, a neurosurgical tool, if you will. And the work that they've done with brainstem gliomas, preclinical work, is pretty meaningful if you look at the success of getting I think this was doxorubicin, but getting your drug in your target tissue with an enhancer, in this case, focused ultrasound. I know that there's been a recent FDA-approved trial in DIPG, not up in Toronto, but another group that hasn't been released yet. But soon online will be the same with regard to potentiating drug delivery. Obviously, that's just one part of the equation. The other is the drug. Oncolytic viruses, with malignant gliomas. The work that Jim Markert has done, beautifully down in Alabama, really paves this path for looking at this in pediatrics as well. The DNX 2401. This is a group in Spain that's using direct drug delivery with an oncolytic virus and DIPG and H3K27 mutant tumors. Again, the backbone is the same. The therapeutic molecule is different. And then starting to answer other questions about how do we do this in a more meaningful way that kind of marriages what we know in oncology already. It's pretty foolhardy to think that a single dose of chemotherapy is going to cure a germ cell tumor or a low-grade tumor. This idea of repeated delivery is very important, and industry is certainly rising the occasion. But I can tell you that until we see clinical benefit, this is going to be somewhat stifling to get industry to really come to this. I wanted to pretty much close with kind of the interest and the fascination of what's going on with high-grade gliomas in kids right now. And I do find it very exciting, but embedded in this, and this is just a sample, this is not every open clinical trial by any stretch. I've kind of intentionally avoided the cytotoxic chemotherapeutic regimens, even though those are still the robust backbone of high-grade gliomas. But some of the things that are going on that I think are of interest, and I love that these have translated to early phase clinical studies, because it tells you that regulatory and oncologists and we as a group are so frustrated. If you go back to that first MRI I showed you with a GTR and a kid who recurs after very intensive cytotoxic chemotherapy and radiation therapy. So HDAC inhibitors, this should be published soon. This was intentionally used for recurrent DIPG. There's an arm that still remains open for those before recurrence after radiation therapy. ONC201 and H3K27 mutants, again, a lot of airtime right now. Susan Gardner at NYU is, I don't know, 7 different, I think, arms to that study, depending on the tumor, not just phenotype, but location, treatment, previous treatment or not. Optune, which, I think it's the first clinical trial that's being used in kids with progressive supratentorial malignant gliomas. That was through the PBTC, and they just opened up an arm for posterior fossa as well. So there is a arm to include DIPG and H3K27 mutant tumors in the posterior fossa. The group at Columbia has taken Jeff Bruce's sentinel work in the supratentorial compartment in adults and now given chronic administration of topotecan to these types of kids. And they just opened up their study as well, utilizing MTX-110, the same agent used in that UCSF study with a chronic delivery system over a period of, I think, 8 days. I love that this is translated into an early phase clinical study with the group out at Stanford, Michelle Monge and colleagues utilizing GD2 specific CAR T cells. GD2 has been something that we've targeted with 8H9, similar type of epitope. But this is fantastic that this will open up soon with regard to cell-based therapy in kids with malignant gliomas. I honestly don't know, but I believe it also includes those in the supratentorial compartment, providing they're classified as a DMG with the malignant phenotype. Combination therapy, which has been really, really hard to translate this into clinical work. This is set to open, if not next month, hopefully by the end of this calendar year, of using an HDAC, pan-HDAC inhibitor with a polyosome inhibitor, marizumab. And this is going to be fascinating from the standpoint of some of the great work that was done at the NCI by Craig Thomas, looking at combination therapy with high throughput drug screening. So really, really interesting. And we're in the final stages of our phase 2 study, which is being an international effort looking at direct drug delivery with radio-labeled monoclonal antibody. So the fact that these exist, these highly innovative therapeutic strategies for malignant gliomas, really begs to the idea that we have failed and we have not done a good job, but also begs to the scientific community who's done a phenomenal job in the early translational work, and I think regulatory as well for recognizing the need. I'd say that in looking at this from a historical perspective in my career, I get so frustrated, and I go to the OR with a little bit of guilt, thinking that I'll do a great job, I hope, but unlikely can I have that same type of conversation with a parent. Some of these adjuncts that we spoke about, intraoperative MR, fluorescent imaging, tractography, and all the bells and whistles that we use, I don't see this as, the difference of a couple % of contrast enhancement is going to be meaningless in my opinion, and I might stand alone in the neurosurgery community by saying that. But I do think, as I've just outlined, hopefully, that there is the capacity, and we've seen this with targeted treatments in systemic cancers, rarely in intracranial tumors, the SEGA, that if we can define that there is certainly that opportunity. And Lily presented great work with regard to mutational status and targeted delivery in low-grade tumors. And I don't think we're going to go away. I think all these tools that I've highlighted, focused ultrasound, intraarterial, CED, intrathecal, I didn't even comment on. We're still going to have to be, to some degree, the purveyors of those technologies. But I'd say that we as a community have to be really, really smart about how we're applying those, and not just be the technician, and really think about things such as dosimetry, frequency, drug scheduling, and lay this out in a preclinical platform that doesn't make this a flip of a coin as you move into very expensive venues. And then no question about it, I now, rely on our molecular pathologists and our oncologists. Should I resect an IDH mutant tumor that I think I can get out? Lily showed you a great example of maybe the mindset should change, that the upfront therapy isn't going to be a radical resection. So with that, I'll close and just say it's a very exciting element in time for us. And I think that compendium and that network of individuals and experts who play into our decision making is becoming increasingly complex but important. So thank you again, Heather and Toba.
Thank you. Thank you to both of you for taking the time and being here with us this evening. So we have a couple of questions from the audience. The first comes from one of our oncologists here. So what I'm assuming Dr. Khatib is asking is if in posterior fossa tumors that have low-grade gliomas, if subtotal resection is not achieved, why not use focal radiation more often?
So I presume that is towards me.
Yes.
For the low-grade gliomas. And I think that the answer to that is we have very effective therapies based on the molecular analysis of low-grade gliomas. So I think if you have a lesion that you can only subtotally resect, and I think, again, sort of to reinforce the point that Mark was making, we need to think of quality of life and survival. So if there is a potential that you're going to cause a neurologic deficit, do not do an extensive resection, do molecular typing. There are very good drugs for low-grade gliomas that will have excellent long-term results. And I think the other thing to remember is these patients will survive as long as you can carry them until age 22, 23. So once they hit that age, then their tumor turns off. So I think, whereas chemotherapy, with the very few exceptions of causing the MDS, but that's not the standard chemotherapy that we use for low-grade gliomas, they don't have the long-term complications of radiation therapy, which are not reversible. So the reason not to give radiation for a subtotally resected low-grade glioma is that you have effective targeted therapies that you can use. And it's impossible to go through all of them, but there are drugs that are looking at the BRAF not mutation, but the duplication fusion that are effective. So I would use that approach and treat the patient with chemotherapy and not radiation therapy, because the radiation therapy is irreversible. If they develop a second malignancy, then that patient is going to die from that second malignancy. So I feel very strongly that you should exhaust all other avenues before you do radiation therapy.
Thank you.
If I can emphasize something that Dr. Gumnarova said in her talk, she used the phrase chronic disease, and that is introduced into my vocabulary more than ever when I'm speaking with parents, especially with low-grade phenotypes, not to mention cranios. But I think that I look at the harm that has been done to these kids, and most of it is therapeutic. It really, I'm not going to listen. Kids get blindness from optic pathway gliomas and hydrocephalus, et cetera. But I've seen a lot more detriment from therapy in a combined fashion, a surgery that's overly aggressive, radiation therapy meant to cure, intracavitary therapy. The list goes on. And I just think that this idea of thinking about these as chronic diseases, most of these kids are functionally very good by the time they see us, if you can treat their hydro. So I agree wholeheartedly with Lily that one has to be reserved and measured about how you're treating, and not put on this mindset of, I want to cure at this point in time, especially in the low-grade phenotype.
So our next question, and I'd encourage other participants, please ask away on any questions you may have, because we'd like this to be as interactive as possible. But our next question is kind of a follow-up to that question, actually, and I think directed at both of you, because it'd be great to get both of your opinions. One of our participants asked, for low-grade glioma that makes it into their 20s and the tumor stops growing, are they more susceptible to acquire different adult brain tumors? And you had touched on that. And what is the quality of life for these patients?
Okay, I can start, and Mark, you can obviously chime in afterwards. I think that for the patients that we have followed, there isn't any evidence that they will develop other tumors. So I think that once they get into their 20s or whatever, even if there is residual tumor, what we do know is that actually that remains stagnant. So a number of patients with small residual tumors, you can see it on follow-up imaging. It doesn't do anything. They don't develop other tumors. And maybe there are case reports out there, but I'm not aware of patients who then suddenly develop another tumor. I'm sure that probably they will develop that, but it's probably not related to their primary brain tumor. The second part of that is what are the side effects or the long-term side effects. Those are related to the therapy that we have given those patients. So whether it's complications from the surgery or complications from the chemotherapy or radiation therapy. And I think in that paper that I had included an outcomes data from the SEER database, there are a number of other analyses that looked at other long-term effects. And I think it's really what the initial therapy is. Those are the long-term side effects. But once they hit their 20s, they're not going to develop anything new unless you've given them a therapy that is going to cause new things. And that's where the radiation therapy comes in. Mark?
Of course, not of course, but I will agree. And that is, I think, as we talk about pediatric neuro-oncology, there's embedded in our minds, the late effects, the survivor programs, and the beautiful work that Roger Packer has done in 40, 50 years of outcome analysis, looking at, secondary tumors with medulloblastoma. That's just indelible. And you watch this, and in every decade, there's an X% increase in secondary tumors, malignant or otherwise. That doesn't necessarily follow the same path in the low-grade phenotype. So I would agree with you. I don't know of any evidence that points toward a predisposition to second tumors.
And I think one of the other things that I want to kind of make a point, and you certainly addressed that as well, Mark, this is where it's crucial that you have a multidisciplinary program and you have outcomes clinics so that you can follow those patients. It used to be that a lot of the patients with low-grade gliomas were followed for 5 years and people would say, oh, I don't need to see you again, don't come back. That's not true. These patients really, going back to the paradigm of a chronic illness, they need to be followed. And we don't know until what age, but certainly I think they need to have long-term follow-up to really answer those questions.
So the next question is really kind of piggybacking on that. Is there any theory behind why they stop at that 20, 21, 22 year of age, especially in these low-grade gliomas?
I don't know that there is an explanation as to why that happens. I know that that's the analysis, and it isn't only our data set, but there are a couple of other papers that looked at SEER databases looking at outcome in low-grade gliomas, and they all showed similar time point. Mark, I'm not sure. Do you know? Are you aware of any explanation?
Not at all, but I want to thank Dr. Regev for challenging us with that question.
Yes, I saw it was him, so thank you, John.
We're not invincible. There you go.
One other question just along the same lines is, how often are you recommending imaging for these low-grade glioma patients? That seems to be something that we get asked often. And so once they hit a time period where you don't see regrowth within 3 or 4 years, do we continue to image them yearly? Do we go every 2 years? What is the correct answer for that? Or what is your management of that?
Well, of course, I am biased because we published a paper on that and the recommendations for low-grade gliomas. And it's not necessarily universally accepted, but certainly after 5 years of age, the follow-up can be really fairly infrequent. So the question is, can it be, it does not have to be every once a year. There's clearly data that it doesn't have to be that frequent. Can it be every 2 years? Possibly, but and I would refer people to the paper because we have a very nice algorithm there where we show, and in the first 6 months to a year there needs to be frequent follow-up. The first 5 years less frequent, and after that it's unclear how beneficial it is to obtain yearly MRIs. And I think as a group we have all been over imaging patients. It also provides some both reassurance and anxiety to the patients and the parents. I know a lot of parents want to have the imaging, but I think that over time with counseling, we can probably switch this paradigm and decrease the amount of imaging and follow-up.
Another question for both of you. You talked a bit in your talk about the shifting paradigm of who you biopsy in terms of optic pathway gliomas and hypothalamic gliomas. Maybe you could share what your current thoughts are on who should have upfront biopsies, what the characteristics are. And then also I'll throw at both of you. I know the answer, but I think it's helpful for everyone else. What do you say to new DIPG diagnosis patients about the role of biopsy as well, both pre and post radiation? I'll give that to both of you since I know you both have thoughts on it.
Mark, do you want to start or do you want me to start?
Sure, I can start. And I was and have been, Heather, you know, fairly vocal about the, I won't say resistance, but adopting a universal biopsy when I see somebody with an L stress. And I know there's variants, but typical presentation radiographic imaging of a child with DIPG. And I still hold true to that to some degree. I won't discount the value added, what we've learned, the direction we're going. One thing that bothers me in this idea that it's so crucial and important is the diagnostic inaccuracy, I think, of high volume centers is exceedingly rare, especially with the imaging that we're throwing at these kids. And I also think seeing a lot of children come to us for entry into clinical trials, but the morbidity is not as low as the Paris group, maybe in their hands, but I think a lot of these kids are now being basically managed by individuals and or centers that don't see the same type of volume. So it's not single digit percentages, I can tell you, listening to parents talk about what happened after the biopsy. But I think that the diagnostic inaccuracy is overinflated. Mike Handler published a really nice paper over a decade ago about, I think it was a series of patients and images he sent to pediatric neurosurgeons for consensus about variants. You can self-select. I'm not going to say it doesn't exist, and we scratch our heads. And if there's any hesitancy, we biopsy at a very low threshold. So, but as adopting this as a universal policy, I still think we're not there. And the analogy I always use is in GBM, where we have tons of archived tissue and cell lines, and in every format you want, we are no further afield than we were when I started my career 3 decades ago. So you can do all the genomic sequencing and whole exome sequencing, and we have cell lines bulging out of our freezers. But I think as an adoptive universal policy, I still hold strong against it, but rely on it inherently when there is a question. I'll let you tackle the low-grade tumor, Lily, unless you want to counter, or anybody wants to counter me with regard to the universal aspect of this.
I think you can give your thoughts on high grade too, and then low grade as well.
Me? Yeah. So it's interesting, I'll just answer for the high grades because we were part of the initial North American study. Nailan Gupta from UCSF and Mark Kieran and I were leading the trial in North America on biopsy for DIPG. And I think our morbidity was very, very, very low. But I think it is important to recognize that it's, a different experience and different volume. And I think there is no doubt that volume and experience does actually help. Having said that, I also know of complications from very experienced high volume neurosurgeons. So no one is immune from that. And I think it always has to be a very balanced and very thought of decision with the families and the patients and the physicians as to what the goals are. And I think the same can be said about the optic pathway gliomas. I think, though, the morbidity from a biopsy in an optic pathway glioma is probably less than that associated with the DIPG, although I think both can be done fairly safely. So if you're just going to do a biopsy of an optic pathway glioma, again, you need to think of how to do that. It can be done safely. There is no doubt that I think there is a benefit because now with the targeted therapies, we actually will have more options other than just the standard Vinc carbo for low-grade gliomas. And I think that is going to make some impact, unlike the DIPG where we don't really have good therapies. For the low-grade gliomas, we do have therapies. So I personally would say if you have a center that has a large volume and a surgeon who is experienced with low morbidity, then I would think it's a reasonable thing.
So I'm going to jump in, Heather and Toba. I'm going to put you on the spot. So one of the things that's always has challenged me of late with a radiographically highly suspicious optic pathway glioma in a child who is otherwise well, let's call it incidental. How do you handle that? Do you or do you not biopsy with this promise that you're going to move forward with targeted therapy?
So asymptomatic child that this is incidentally found, I think that really warrants a discussion with the family. Again, you could look at it two ways and offer them a biopsy, or alternatively wait and re-image and see if there's been progression. And at that point, you can intervene. I think that there's no harm in waiting as long as the child is asymptomatic. I think that's usually where I err on the side of always trying not to cause any more harm as long as the child is okay. I don't know about you, Heather.
Yeah, I mean, I think I agree. I think it also depends somewhat on what it looks like on the imaging. Is this a small lesion that is mostly in the optic tracts, or is this a larger lesion where it's easier to see a clear path to biopsy without harm? And then are they symptomatic or not? I think plays into it as well. So Mark, I agree about potentially watching.
Mark, I was going to actually say something, and I don't think that every single lesion you identify on an MRI needs a biopsy or therapy for that matter. So I think we're talking about these, and the patients that I showed are these humongous lesions. But there are a number of patients who have very small lesions, either in the context of an NF or not, that are in the optic pathway area, that the patients are completely asymptomatic and don't have any deficits, including a formal ophthalmologic evaluation. Those patients probably do not need any therapy. They just probably need to be observed. So I think every patient needs to be evaluated and individualized therapy, individualized treatment. Not everyone needs an operation.
I agree. I think our last question here before we conclude, since we're getting towards here 6:30, is several possible molecular targets were presented for low-grade gliomas, but they were wondering if there's any possible role for the use of PD-L1 inhibitors.
So I'm not familiar with the PD-L1 inhibitors, so I can't really comment, but I think that there are a number of therapeutic targets. And I think there's always a role for new drugs.
I was going to ask Heather, the scientist. Yeah, so whether or not, I think there's been a lot of enthusiasm. But, this idea that you need infiltrating lymphocytes in the tumor milieu is, has always been one of the hindrances of jumping into this. But obviously, it's been in the high-grade phenotype that they've been introduced with vigor. But again, without much proven efficacy to date.
Yeah. I think it's exciting to see how things pan out. I mean, I think we need so many different angles to tackle these tumors, and hopefully something will start working for some of these higher grade lesions.
All right, well, I think that, we just wanted to thank you and everybody who joined us for, especially the two of you, for giving us your time. Go ahead, Heather.
Yeah, this has been a fantastic session. So thank you to both of you for your wonderful talks and for answering everyone's questions. Thank you for our participants who joined in, and especially those who asked questions to make it a bit more interactive. And we're looking forward to our next session will be in December. We're going to focus on hydrocephalus for that one, do a couple other different pediatric neurosurgical topics before we probably circle back to tumor at some point at a later date. And so we'll be sending out a flyer soon with the next announcement. So thank you so much to everyone for joining.
Yeah,
And
thank
you.
Been a lot
It
of
was
fun.
a pleasure.
Thank
And everyone have a safe night in Miami.
Thank you.